Hi, good evening. My name is Lorraine Carugda and I'm your provider for today. Today we will be doing your GI, your musculoskeletal and neurological assessment if it's okay with you.
Yes.
First, what is your name?
Robert.
Your date of birth?
July 15, 1970.
Do you know where you are?
Yes, in the hospital.
Do you know what the day is today?
October 15, 2023.
The patient is awake, alert, oriented times 3. Do you have any pain?
No.
Do you have any allergies?
No.
And it's okay with you, correct?
Yes.
Thank you very much. And for better visualization of the area, the patient took off already or removed his clothing. So I wash my hands and gather my equipment and provide privacy. So I will proceed with the inspection of the abdomen, noting for any color, any past surgeries, noting for any masses or any presence of colostomies or ostomies. I will position myself at the foot of the bed, noting for any distension. Distension could signify fat, fluid, or tumors. Noting for any peristalsis. Peristalsis is visible on the obstruction or intestinal obstruction of the patient. Also for the color of the umbilical region, bluish discoloration of the umbilical region can signify Scollin sign, which should signify ruptured ectopic pregnancy or acute necrotizing pancreatitis. Also gray Turner sign, which is positive discoloration on the lower portion of the belly towards the posterior portion of the patient that could signify intraperitoneal bleeding or intra-abdominal bleeding. Then I will proceed with the auscultation of the bowel sounds, starting from the right lower quadrant to the left lower quadrant. Bowel sounds are normal, hypoactive, and hyperactive. Listening in each quadrant, in each quadrant 2 to 5 minutes, wherein normal bowel sounds are 5 to 35 bowel sounds in each minute. So hyperactive bowel sounds could signify irritable bowel syndrome or diarrhea. Hypoactive bowel sounds or absent bowel sounds can signify constipation or intestinal obstruction. Then I will proceed with the auscultation of the aorta using my bell of my stethoscope because of the low-pitched sound of the bruit. Aorta is just above the umbilicus, and then the right and left renal artery, and then the right iliac and the left iliac artery. And if there is a need to assess or to listen for bruit in the inguinal area, we'll do it so. Then I will proceed with the auscultation of the bruits are similar to hard murmurs. Then I will proceed with the percussion of the abdomen. So in percussion, noting for any tympany in the abdominal area or the small intestine because that is normal. Anything that you percuss dullness, that signifies ascites or organ enlargement. And in the umbilical region, it could be hyperresonance. If there's hyperresonance all over the abdominal area, that could signify aneurysms or varicosities. Then I will percuss for the liver. So I will start in the right mid-clavicular line of the patient. I will start percussing, noting for tympany. Then after tympany, whenever I hear dullness, I will mark it with a marker over here. Then afterwards, I will proceed in the right costal margin mid-clavicular line, moving downwards. Then I will measure it by a measuring tape, and it should be 6 to 12 centimeters. Anything beyond 12 centimeters signifies ascites or organ enlargement. Anything below 6 centimeters signifies liver atrophy. Then our percuss for the spleen. Usually the spleen is on the left side. So I will percuss for the spleen towards the left, noting for any dullness. If there is dullness, that could signify liver enlargement that could warrant you to proceed with the palpation. So in palpation, I make sure that I warm my hands, and I will demonstrate light palpation using my palm surface of the hand, only depressing 1 centimeter on the abdominal wall. With the deep palpation, I will use 2 hands, same procedure, and then percussing it evenly and deeply in the abdominal wall. So we have, I will do some percussion, noting for McBurney sign, which is common for appendicitis. So I will start from the umbilicus towards the right, noting for any rigidity and tenderness. If there is positive for tenderness or rigidity, that could signify appendicitis. Then I will proceed with the palpation of the abdominal aorta. Aorta would be here. So there are two ways. You could do this or you could do this. So estimating the diameter of the aorta, it should be less than 3 centimeters. Anything beyond 3 centimeters or above 3 centimeters could signify abdominal aortic aneurysm, which warrant you for further studies. Then afterwards, I will palpate for the position of the liver border, which is on the right side. So in palpation, I will place my left hand underneath the patient's abdomen, and I will place my right hand above, and I will tell the patient to take a deep breath, and as the liver should be meeting my fingers, and that is how to palpate the liver border. And also I will do the palpation of the spleen, which is on the left side. I will do this, place my left hand on the back, place my right hand on the front, palpating for the enlargement of the spleen. Any palpation of the spleen could increase the risk for fracture. And the last will be palpation of the kidneys, right and left. So I will start with the left side. Usually the left kidney is non-palpable. So I will reach, using my left hand, I will reach and lift, and I will palpate for the left kidney. Left kidney should not be palpable. Upon palpation, if the patient has pain, do you have pain? If the patient has pain, that could signify infection. And I will do it on the right, putting my left hand, putting on my right hand, and I will be palpating for smooth, firm, and solid organ. If the organ is soft, it could signify chronic kidney disease. Then we're done with GI. We'll proceed with the musculoskeletal system. Can you please stand, face the camera? So I will be proceeding with the inspecting for the shoulders, clavicles and scapula, noting for symmetry, bruises and tenderness. Bruises and redness could signify trauma, especially or falls, especially for elderly. Then I will note for landmarks. This is the suprasternal notch, noting for the joints. So this is the sternoclavicular joint, palpating towards the clavicular or acromioclavicular joint and acromion process. If there should be no discomfort bilaterally, and if there is hollowing on the acromioclavicular joint, that could signify fracture. And also noting for wasting or muscle wasting of the deltoid muscle. Then I will do the range of motion. So you will rotate the head, the neck first. So do the rotation on each side. Then I will do the abduction and adduction of the shoulders. You follow me. This is abduction and this is adduction. And for the flexion and extension of the biceps and triceps as well. And afterwards, we will do the palpation of the pulses. We have the brachial and the radial pulses, which is 1 full minute. Then we'll proceed with the reflexes using my hammer. So I'll do first the bicep reflex. Let the patient dangle. I will just locate the biceps. I will put a blow, noting for jerking movement of the forearm and contraction of the biceps. Then I will proceed with the brachioradialis, 2 to 3 centimeters above the wrist. I will put a blow, noting for any jerking movement or contraction of the forearm. The last would be the triceps reflex. Let the patient dangle freely. Locate for the triceps just above the elbow. I will put a blow, noting for jerking movements. Again, jerking movements of the forearm and contraction of the triceps. Then I will proceed with the strength. So with the strength, I'll do this. Can you please move against the resistance? That's for the biceps. This is for the triceps. Push against me. So the green is 5-5 movement, 5-5 movement against gravity and full resistance. And I will palpate for the hips. So I will cover for privacy, palpating the hips, starting from the anterior portion towards the posterior portion, noting for any pain and tenderness. If there is pain, it could signify fracture or trauma. Then I will proceed with the reflexes. So we have the flexion, putting the knee as far as possible in your chest. That's active range of motion. Or I could do it passively. I could help the patient do that. Then we have adduction. So I will lift this leg, move your feet. That's adduction, and abduction is moving away as far as possible. And then afterwards, can you do prone position? Then I will do the extension of the hips. Can you lift your leg up? That's passive, or the patient could do it actively. Thank you very much. Then we could proceed with the lower extremities. With the strength, sit down, please. Strength of the hips. Push against the resistance. So 5-5, that's the score. Then we'll proceed with the lower extremities. With the inspection first of the location of the kneecap or the patella, it should be even or symmetrical. There should be no edema. Temperature, check or note for any swelling. Also, we'll do the reflexes. So we have the patellar reflex. I will note for the tendon. Tendon is like a cord-like area. So I will put a blow, noting for, again, noting for jerking movement of the feet. Then I will do it bilaterally as well. Then we have the Achilles, do like this, Achilles reflex. So I will note for the heel, I will put a blow, again, noting for jerking movement. And the last would be the Babinski face here, using my dull portion of my hammer, noting for a neutral response, not fanning, because fanning could signify neurological abnormality. Then I will do the pulses. So we have the popliteal pulse. Maybe lie down. Popliteal pulse here. So popliteal pulse, back of the knee, relax. Then we have the dorsalis pedis, popliteal knee at here, and the dorsalis pedis and posterior tibialis. So it should be 0, or it should be 2 plus 2, that's normal, 0 for absent and plus 4 for bounding. Then we proceed with the spine. We're done. Oh, sorry, flexion extension. Flexion extension of the knee. This would be flexion, this should be extension. Then with the fingers, I forgot, so we have the flexion for the fingers. This is the extension, and this is the flexion. Also with the, this is the wrist, sorry. This is flexion and this is extension. And for the finger, same thing, flexion and extension as well. And then abduction and adduction. Good job. Then we'll proceed with the spine. So stand up. Spine, noting for kyphosis, lordosis, or the posture of the patient. So with the patients, the posture is normal. Concavity and convexity of the thoracic or the lumbar portion. Then I'll proceed with the cranial nerves. So I will first do with the, where is my orange peel? So first we will do the olfactory or cranial nerve 1. Close your eyes. Tell me what is now. So correct. This is orange peel. And then with the cranial 2 nerves, we will do the cover and cover test. Cover, noting for any deviation or any strabismus. The other side, noting for any deviation or any strabismus of the pupil. And also, with the patient, there is none. Also, cranial nerve 2, this is we use the Snellen's chart, wherein we do the vision of the patient, noting that the patient could read the smallest letter, and that corresponds with the vision of the patient on the number beside it. And next cranial nerve would be cranial nerve 3, 4, and 6, noting for extraocular movement. Only follow only follow it with your gaze. Perla, which means pupil equal to round, light, and accommodation. So noting for the pupil size of the patient, 3 millimeters, and also for the constriction of the pupil. Then we will proceed with the fascia or the trigeminal, noting for the ophthalmic, maxillary, and mandibular. So tell me if you feel the sensation in both areas. You could use the fingers, or I could use this one. So you could feel the sensation, correct? Different parts, and then clench your teeth. And then noting for the masseter balls and the temporal balls, it's even. So this is normal. And then I will proceed with the facial nerve. So ask the patient to raise eyebrows, smile, frown. That's no problem. Then I will proceed with the hearing acuity. Tell me what do you hear?
1, 2, 3.
And then that's correct, and do it also by lap in the other ear, also with the Weber's and Schreiner's test, which I've done it in the previous assessment. Then I will proceed with the cranial nerve 9, glossopharyngeal, vagus, and the hypoglossal, and I will ask the patient to say noting, protrude your tongue, noting for the movement of the uvula, and also for the movement of the gag reflex. Okay, that's good. Also, I will ask the patient to swallow. If there is no problem swallowing, there would be no problem. And can you say good morning?
Morning.
And check for the speech if it's clear and not slurred. And the last would be the cranial nerve 11, is spinal accessory. Shrug against my shoulder, move to the other side. No, hold on. There's no resistance, move it over here. There's resistance, so there should be no problem. Then I will proceed with the neurological assessment of the sum. The rapid alternating movement, pronation, 10 times, finger, Perfect, no problems. And I will also do the heel to chin test, noting for lower limb coordination. Heel to chin, do it bilaterally. Anything that's problems with the dysfunction of the brain. Then also with the extroreceptive sensation, wherein I will ask the patient if the patient could distinguish dull using a pin. Dull. Oh, you can tell me if it's dull or sharp.
Dull.
Okay, doing in different areas.
Sharp.
Also, if the patient could determine hot and cold.
Hot. Hot. Hot.
Very good. That is for the temperature. And also with the proprioceptive reception index finger. Close your eyes, tell me if it's up or down.
Up. Down.
You also do it bilaterally, also with the toes.
Up.
Very good. And then for the vibratory senses, tell the patient to lie down. Okay, I will activate the tuning fork. Place it on the interphalanges. The patient could feel the vibration. Can you feel the vibration? If the patient couldn't feel the vibration, there is a problem with the peripheral neuropathy. The next would be the stereosignosis. Sit down. Tell me, close your eyes. Tell me what object did I put on your palm?
Pin.
Okay, other side. Close your eyes.
Coin.
Very good. So you can do it with a pin, a key, or a paper clip. Then the X would be identifying letters. Open your palms. Tell me what letter did I write.
A.
Other side.
L.
Very good. No problems. And last two would be the Romberg's and the Romberg's sign and the pronator drift. So I will also observe. Close your eyes. I will guard the patient, check, count 1 to 10. If there, no, close your eyes. I will count 10, 9, 8, 7, up to 1, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. There should be no swaying. Swaying that's noticed is a problem with the cerebral function. Pronator drift, put your arms front like that. If there is a drift, close your eyes. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. If there is a drift, there is a problem with the voluntary movement of the neuron for the spine and the brain. Any questions? Thank you very much.